It's February 17, 2022, and welcome to Leaders on the Frontier. My name is David Leeson. I'm your host, and the Frontier Center for Public Policy is about better public policy for a better tomorrow. We are an independent and nonpartisan policy think tank. Our topic today is Canada's healthcare system. Is it serving you? How do we make it patient-centered? And what indeed are the solutions? But what you ask, don't we have a great healthcare system? Well, that's the question. And sadly, despite having great people in that healthcare system, the facts do not suggest that at all. Consistently, Canada's healthcare system is ranked at the bottom of all international rankings in the OECD countries, and we are the second most expensive in the world. Canada is a leading example of an underperforming healthcare system. Today, I would like to introduce our guest, Dr. Brian Day, and I want to introduce him by saying Brian Day is a pioneer in arthroscopic surgery and sports medicine in Canada. He was involved in developing the world's first surgical robot and the first ever satellite telemedicine broadcast between North America and China. He was the recipient of the Canadian Orthopedic Association's Edward Sampson Award for Outstanding Research, and he is a former research committee chair and past president of the Arthroscopy Association of North America, the world's leading academic society in the field. He has lectured worldwide and has published over 200 articles and book chapters, and he is the past president of the Canadian Medical Association. And despite the deterioration of our healthcare system, Dr. Day is an optimistic physician who has been a clarion voice for change. And in particular, he is the founder of the Cambie Clinic, which is involved in court actions in British Columbia to overturn, the ban on private healthcare services. A warm welcome to you, Dr. Day.
Thank you, David.
Brian, I'm so glad that you could join us today. We certainly got a lot of ground to cover in this far-reaching discussion. I think it'll be fascinating. I did want to talk a little bit about your background, and beginning with the question, why did you decide to become a physician?
Well, it's an interesting quick story that my father initially had a degree in science, but was not working in that field directly, and then decided to go into pharmacy, and so he became a pharmacist, and I used to help him in the pharmacy shop when I was in my early teens, and they were called chemist shops in England. And anyway, I was headed towards being a pharmacist, but all the doctors that came in to see my father persuaded me to go to medical school, and so that's the route I went, and that's a long time ago now. So it's been a long journey. I came to Vancouver in the 70s as a trainee in orthopedic surgery, and stayed.
And can you tell us more about your specialization?
So I'm an orthopedic surgeon. I was initially a trainee in trauma, like broken bones and serious trauma. I trained in Switzerland. After my training in Vancouver, I spent time working in Switzerland, in Belgium, in England, and in Los Angeles, including the LA County. So I saw a lot. I was trained in trauma, and then I came back, and the specialty of sports injuries was something I got very interested in. So I've treated sports athletes from around the world, famous athletes, world-class athletes from Europe and South America, and as far away as Russia and Australia, Olympians. So that's been my specialty now for many years.
That's interesting. Brian, it's fascinating as I've talked with so many people over the last few years as we've gotten to know each other. Your name comes up, and so many physicians that I know say, wow, you're very fortunate to get to know Dr. Brian Day. He's really a legend in terms of medical care that you provide, but also the kind of leadership you've given. Now, you've been president of the Canadian Medical Association as well.
Yes, the Canadian Medical Association is a very old society. It's only 3 months younger than Canada. So it's formed in 1867. They've only had one orthopedic surgeon as their president, and that's me. I went into it. I became interested in medical politics because we weren't being allowed to function as surgeons in this system. And I know you're going to question me more on that, but that was my motive for trying to get into what, the field of quotes medical politics and introduce some change. And I found it was a lot more difficult introducing change than I thought, but I think I made some progress.
So let's talk about the Cambie Clinic. I know that from friends of mine that have benefited from experience at the Cambie Clinic as a patient, no less, they very much appreciated the clinic. I know it's highly rated on all indexes. Why did you found that clinic? Can you tell us briefly the history of that?
Yeah, so when I came to Canada in over 40 years ago, the system was fine. I mean, there was only basically a public system. We had no wait lists. Patients got treated right away. Certainly, but during the mid to late 80s, it started to deteriorate. We found that patients weren't getting access. We found that doctors had their operating time rationed. So mine, for instance, was progressively cut from 22 hours a week of surgery down to 5 hours. The minimum recommended for competence by the Canadian Orthopedic Association is 13 and a half hours. So that was almost a third of the recommended minimum time. And then equally, I was in charge of the training orthopedic surgeons in British Columbia in their academics, and I was actually chairman of the Royal College test committee for graduating orthopedic surgeons in Canada, and found that we were training them, but we couldn't give them jobs. They were not being allowed to operate. And so by the time it got to the late 80s, early 90s, we decided we were going to do something about this. And if the government wouldn't let us take our patients to their hospitals, we would build our own hospital. And basically that's what we did. A lot of us had chances to go elsewhere, but we wanted to stay in Vancouver. And
so just to clarify that for kind of a layperson's perspective, you have these incredibly highly trained, specialized physicians that really can't practice because of the rationing or the availability of the operating theater. They're not available. Is that kind of a key?
Yeah, so of 60 over a 4-year period in the early 90s, 5-year period of 16 trained orthopedic surgeons that we had trained at UBC alone, only 5 could get a job. The others had to leave for the United States. And so to give, I have a sample of an operating room slate in actually a few months before we opened our surgical facility in 1996, and in a full week of 20 operating room day sessions, 13 were completely closed, and of the 7 that were open, 5 of them closed. Were only open till 3 p.m. This was all based on rationing, because what was happening is governments were beginning to find that they couldn't afford to keep the promise of treating patients when they needed the treatment. And so patients were not getting access to healthcare. And the way they did it was by rationing access to operating rooms, rationing access to doctors and nurses.
So it seems like there's this almost kind of a bizarre scenario that maybe many people are not aware of, where you have the rationing on one hand of the service provider because they can't get the operating theater. On the other hand, you have waiting lists, people who are waiting years, many in chronic pain, trying to get that service. And so there's a complete mismatch of resources.
Well, yes, and literally, patients were suffering, not only suffering, dying on wait lists, and that was something that it all relates to the fact that we had a system with capped funding. I mean, hospitals were given what we call a global budget to operate each year. And that budget, when it started to run out, the only solution was to stop treating patients. And that's the case today, that one of the biggest problems is that hospitals are not capable of fulfilling their promise to treat patients in an accessible period of time, in a reasonable access, with reasonable access. And,
Wow.
and that's the problem. And meanwhile, today, for instance, we have over 200 young orthopedic surgeons in Canada, fully trained, who cannot get any operating time, even though the biggest wait lists are in orthopedics. And that's just orthopedics. Wow. The same applies to other specialties.
So this is probably a shock to many people's ears. Now you're an insider of sorts within the system. You have enormous experience and perspective. And it's been interesting as I've talked with you, Dr. Day, that you've made the observation, in essence, that our system, and I think people would be shocked to hear this, you describe as a Soviet-style system. What do you mean by that?
Well, actually, I use the analogy in relation to the fact that we now have laws in Canada whereby non-residents and so individuals from other provinces and other countries have rights within your province that you live in that are denied to you. And you know, the reference to Soviet was the fact that in the days of the Soviet Union, there used to be shops in Moscow, for example, where only visitors could go. You were not allowed in if you were a Moscow resident, if you were a Soviet citizen. And so that's the analogy. And but it's far from, you know, one of the things I do like to point out is this is not, I'm not really calling our system communist, because communist countries do not have laws like ours that outlaw choice and outlaw private options.
Sorry, can you repeat that again?
Yeah, so there are 5 communist countries now, that Cuba, China, Laos, Vietnam, North Korea, and none of them outlaw private health insurance in the way that Canada does.
Wow.
So we have this bizarre situation, is that we have more restrictions on freedom of choice than some of these authoritarian countries around the world have, and that should be a wake-up call for Canadians, that the government has the government's basically taken the position that if you're on a wait list and you're exceeding the maximum safe time, it's their job to decide whether you can go out and get treated.
Wow. So that puts enormous power in the hands of the so-called medical bureaucracy.
Well, it's in the hands of the government. It's not in the hands of the medical bureaucracy, because physicians don't have a say. And to be fair to bureaucrats, you know, I don't, you know, we all hit on bureaucrats, and Canada does have a big problem with an excess of bureaucrats. But that's the mandate the government has given them. So I blame the government for basically directing the bureaucrats to ration access to healthcare.
Exactly. Yeah. Ultimately, it resides with the political masters who ultimately have responsibility for designing this insane system. So, one of the things that I think Canadians would be shocked to learn is that within the system, you really do have to be your advocate for healthcare. You need to speak up and be active. But there's another side to the healthcare system where we call them VIPs, very important people who do get extraordinary access. And you see bits of them as they even come to your clinic. You see so many very high profile celebrities, in fact, come to your clinic because they want high quality, accessible care. But within the public system, what do you mean by VIPs?
So, politicians, judges, senators have all been often funded by the federal government itself, or the provincial government for that matter. You know, one of the I know we're going to talk about it later on, but one of the paradoxes of our legal challenge was the group that instituted and forced the legal challenge that we undertook and our patients undertook was the BC Nurses Union, who actually send us private patients. The defendant in the lawsuit is officially the Attorney General of British Columbia office. They actually send us private patients. The federal government was involved on the side of with the British Columbia government in this legal challenge, and they send us patients. And as anyone knows who reads the newspapers, politicians of all political stripes have gone and accessed healthcare independently, and often in the United States or elsewhere, or else they do what happened in Ottawa sometimes, which is, you know, I gave a talk to the Ottawa editorial board of the Ottawa Citizen, and they used to have a little box in the top right-hand corner of the registration form when you went to the hospital, which had VIP. You had to tick whether the individual was a VIP, which of course makes a mockery that we have an equal system.
Wow. So just to clarify, you're saying that in some of the hospitals, there's actually a form so that as those patients come in, they're identified for having is a better service.
VIP status. Well, actually, that became a front page story after I told the Ottawa Citizen. And interestingly, within a week, the box was gone from the admission forms. But that doesn't mean the process ceased,
Wow.
as you can imagine.
Gosh, this sounds reminiscent of George Orwell's book Animal Farm, where we're all equal, but some are more equal than others, perhaps. That's shocking.
We had an example of that very recently, and and I feel badly for him, but our premier in British Columbia had a cancer, and what happened was there was a front page article in our provincial main newspaper, the Vancouver Sun, pointing out that more than half of cancer patients are waiting longer than the safe time that the government has determined is safe. In the same issue of the Vancouver Sun was an op-ed by the premier praising how quickly his cancer and how effectively his own cancer was diagnosed and treated. And so, and I wish the best for the premier, but it's not equal treatment by any means. When you're a premier, you get better access. And
wow. So there's a kind of an overarching narrative or story about our healthcare system. And you're, of course, very familiar with this book that Frontiers released. It's by senior fellow Susan D. Martinek, senior fellow in healthcare. And it's referred to as Patients at Risk, Exposing Canada's Healthcare Crisis. And it's just released now. It's available on Amazon. And I want to read you just briefly the dedication. I think it's a very powerful one written by Susan Martinock. It says, this book is dedicated to the millions of Canadians who have been denied timely medical care by our supposedly universal, equally accessible, and free healthcare system. Many of these people believe that Canada had the best healthcare in the world and faithfully supported it each year through their taxes, out-of-pocket payments, and charitable donations. They had no idea or no reason to doubt that it would be there to help them when they needed medical care. But when that time came, there was no healing to be found. Instead, they found themselves at the mercy of an archaic entity that is beholden more to ideology than providing care to patients. And as a result, it can legally withhold medically necessary treatment for years. And the only guarantee of care is that it offers an access, to a wait list. Is that your experience, Dr. Day?
Yes, I mean, the data is very clear, as you alluded to in your introduction, that Canada's health system is very expensive. And we're now up to 12.7% of GDP, and one of the top few in the world. I mean, second only to countries like the United States, which is out on a limb on its own, and it's not the model we want for Canada. But I think one of the things the Commonwealth Fund, which is a foundation whose mandate is to advocate and promote better access for healthcare for low income and underprivileged groups. They ranked 10 of the 10 universal systems that they have ranked around the world in developed countries with universal healthcare. Canada came in last, 10th out of 10. And despite the fact that we're one of the most expensive in the world, despite the fact that we have this myth that is widely held that we have a wonderful system, they have no political axe to grind. They ranked us last, and interestingly, at the bottom in criteria such as equity, which means. So what actually Stats Canada shows, and this is Canadian Institute for Health Information, Stats Canada, these groups, that in Canada, the worst health access and the worst health outcomes are in lower socioeconomic groups, the absolute opposite of what the intent was. So I think it's very important to point out that I was never an advocate for privatization of a health system. I just believe that that the monopoly that we have, which is unique in the world, and opposing witnesses in our legal challenge pointed out that no country in the world outlaws an option from and forces you into a state-run monopoly in healthcare. No other country. And so that sets Canada apart, that we're the only country on earth that says you have to go to you have to wait until the government gives you healthcare. And so what happens is the wealthy, by the way, the wealthy have never suffered under any, and this applies throughout the world. The wealthy don't suffer, and the wealthy Canadians don't suffer. They just go down to the United States. So our fight, if you like, 70% of Canadians have what we call extended health insurance, which covers dentistry and pharmaceuticals, drugs, physiotherapy, things that should be covered under and are covered under most other countries' universal health system. But we think that type of insurance should be it should be legal to expand it to cover what the government is not offering in its current system, which is timely access to care for patients.
So this is very intriguing to me, because the facts are that our system is so poorly rated, and yet so much of the narrative that we're talking about today, based on those facts and the stories of so many Canadians that have suffered under the healthcare system, the larger narrative, it would be a shock to Canadians that their system is ranked so low. And I'm fascinated that parties who want this backwards system to kind of continue have been very effective at limiting the debate, blocking any discussion, even vilifying people such as Dr. Brian Day. And I know you can tell all kinds of stories about that. Um, I mean, they even declare people as un-Canadian to dare question about how do we fundamentally improve this system. It's utterly absurd. So why is this? What's going on that would limit this kind of discussion to that degree?
So the reason it's been able to succeed is that at any one time, only a million or two Canadians are waiting for healthcare. That sounds funny to say only a million or two, but that's still relative to the population, not that many. It's a few percent, in other words, and or several percent, and that means until you need healthcare or your loved one needs healthcare, the theory of accessible free healthcare sounds good, but what happens is people get a wake-up call when they need it because it's not there. And one of the points I make is that there's no reason why you can't have a little bit of competition. I mean, countries like Sweden, Denmark, England, New Zealand, Holland, these are not right-wing radical countries. Mm-hmm. They all allow an option of private insurance. And what that does, it's a yardstick by which the government system can be measured and monitored and compared. Whereas governments are anyone with a monopoly is very happy because they don't have anyone exposing their inefficiencies. Mm-hmm. And I think that's part of the reason why this myth can carry on. But once it affects you or your loved ones, if you have a loved one who has cancer or can walk take less than half a block in pain and they're in pain, then you realize, wow, this isn't right that they're told they have to wait months or years for access to healthcare. And it isn't right. And it doesn't happen in any other developed country.
So there a lot of Canadians, because they don't ironically use the system, are comforted by the notion, the illusion that it is a great system until tragically they have to use it.
Yes. I mean, it's like saying, you could offer free automobile insurance, and then as long as you don't have a crash, it's fine. But then when you have an accident, find out that, the insurance will fix your car, but it's going to take a year. And that's not what people expect.
It's crazy. So if we look to the world of solutions, then certainly Frontier has worked with you extensively. We had some of our personnel give witness at your trial based on Frontier's work on healthcare performance indexes, working with our partner in Sweden on that. And some of the principles are very important here. And I know that Frontier's kind of come out and said, well, we need to replace, as you said, Dr. Brian Day, we need to replace the present global budgeting system, say for hospitals. As a former member of hospital boards, I saw that well, where we didn't know what it cost to do, say, a hip replacement surgery, but we did know the global budget of, say, $40 million that we got from the province every year. So you'd replace that, you'd separate the purchase and provision of services to introduce, as you say, competitive pressures. So what are the models that you look to? Where are the solutions?
I think Canada has potentially an advantage now in that it can look at the world experiences and select. It can choose the best from each that that will work in practical terms. But as you point out, under the system where a hospital is given its budget upfront every year, it means that every patient that goes to the hospital is using up the hospital's revenue and money. In every other OECD country, that is not the case. That when in England, for example, whose NHS system was what, and together with New Zealand, those two were something that we modeled our system on. When a public patient goes to a public hospital, the public hospital gets revenue from the government. So those hospitals want patients. In Canada, the hospitals look upon patients as a cost item, and patients are using up the hospital's revenue. So as a chief financial officer of a hospital, if they're going close to the under budget, the first thing they do is cut back on treating patients. In those other countries, in other OECD countries, the exact opposite. If you're low on revenue, low on money or budget, you want to treat more patients. It's a bizarre system of funding that is, and Canada's the only country in the developed world that uses this funding system as its primary, almost exclusively.
So you're saying that we should really fund based on quality results, not in some global.
Well, I think that's one thing, not necessarily quality, but at least, because that's another step that needs to happen. We need to have proper audits on physicians, hospitals, performances, outcomes, because the lower performing hospitals need to be identified, and once they're identified, they will perform better, or else they'll be closed. But I think that we need to make patients a value item when they go to a hospital, not a cost item.
Exactly. And in the meantime, this kind of terrible design, this backwards system that's called Canada's healthcare system, really is hurting a lot of people. And I'm sure you have I know you have untold stories of how this is really hurting people. Is there one that really illustrates that well?
Well, I think, we maybe talk about it a bit more, but that in our trial, we found that in one single health region, Fraser Health, which is just one region in British Columbia, in 1 year, 308 patients died on the wait list without being treated. And
sorry, can you repeat that again?
In 1 year, 308 patients in a single health region died on the public wait list without even being treated. And we know that a large percentage of those patients have exceeded the maximum time they should be waiting. And it was the Supreme Court of Canada in 2005, and this is not a right-wing court by any means, who came out and said that Canadians are suffering and dying on wait lists. That was one of the statements from the Chief Justice when the Quebec Chowley decision came down.
Wow. Well, it's so sad to hear that. So people are not just suffering, they are dying.
And that's pre-COVID. That was pre-COVID.
Well,
the COVID factor is COVID has probably, according to Mohit Bhandari, is a professor at McMaster, has probably in 2020 he came out with a modeling study that COVID would increase wait times between 4 and 7 times. A year later, he revisited it, or their group revisited it, and said they think that's an understatement.
No, the impacts of COVID-19 right across our society, and in particular on our healthcare system, are really profound, aren't they? Will that be potentially a breaking point for our system? We look at the demographics of Canadian society are well known, an aging population. We have the second most expensive healthcare system in the world. We know that inflation is well underway and accelerating. We see our deficits and debts. And obviously, I don't want to be too gloomy, but this is a train wreck. And then meanwhile, no one is talking or wanting to talk at the political level about the desperate need to reform our healthcare system. What's going to break this?
Well, I think it was broken pre-COVID, so COVID is just
That's right.
another.
Yes.
So I think that's why, as I said, we politicians seem to be afraid of this. You know, some people call it the third rail, the electric rail of of political politics. But I think that unfortunately, it's going to have to be the courts that sort this out, and we know that that patients' human rights are being compromised here. That you cannot do. Our position is to basically a trial is you cannot promise healthcare in a timely manner, then fail to deliver it, and then outlaw any choice or option for the patient. You know, one of the paradoxes of our legal system is the exempted groups that you were talking about earlier include politicians because if they're federal employees, and they or if they're from other provinces, and prisoners. You know, one of the bizarre things.
So can you clarify that? How are those politicians and federal employees exempted?
So federal employees are covered by federal funds, and they are able to access. So we're talking about judges and federal politicians. They, you know, these are in the public domain. Some of these stories of how Jean Chrétien went in and, you know, an armed forces jet to the States to get private healthcare. That's not a confidential thing, but we happen to know multiple politicians have done likewise, or at least even within Canada. Or that's if they can't jump the queue as a VIP. So, but we know that there are ways and means that people of influence jump the queue. But the point that included in those federal exempted groups, I mean, the exempted groups include workers' compensation patients, Canadian Armed Forces, RCMP, but also federal judges and senators and MPs who and anyone out of province.
Right.
So it's not a question of equality of access. There is no equality of access in Canada.
And this is in contrast with, say, someone like myself who enters the healthcare system through the provincially funded system that is highly rationed, and most likely you'll end up on a waiting list.
Yes, and it's a system that I think Canadians need to understand is unique in the world. It's unique.
Yeah.
No other country has such a system.
So we truly are a policy outlier when it comes to healthcare.
Yeah, unique on the planet.
Okay. So can you just clarify more about the lawsuit that's happening now?
Yes.
Why is that happening? What do you hope to get out of this? And we're waiting for a decision now at one level.
Yes, we had a decision at the lower court, and that was a decision that didn't shock us because we sensed from day one. This was a trial that went into its fourth year. We had a judge, Justice John Steeves, who had a great difficulty in understanding some of the concepts. He had difficulty with lots of issues, and on the first day or so of the trial, he announced he wanted to disclose that he'd had surgery at our clinic, private clinic, which he had not. So we thought there's something strange, but it was very obvious to us from day one that he had an ideological opposition to, even though he'd been treated at a private clinic himself. It wasn't ours. His was government funded, as we alluded to earlier. The government is exempt from these rules. He but he made many errors, and he came out after a trial that went into its fourth year with an 880-page decision against us. But some of his conclusions were completely strange. I mean, he made just I think listeners and laypersons can understand this, how ridiculous this statement was, that if you wait longer than 6 months for surgery, every month you wait beyond that 6 months, you get 8% better. This was a bizarre ruling. He ruled the evidence, which he didn't understand, was that you get 8% worse, but that's what he came out with a statement that our nurses at our private clinic bill the provincial medical plan, the government plan, which he got from nowhere. I mean, that was a bizarre statement, and we didn't understand it. The sad thing is, this has now gone to the Court of Appeal. It went to the BC Court of Appeal last June, and basically at this Court of Appeal, they mostly look, or the most concerned to them are legal errors, and we believe he made many legal errors, which are more. So we're hopeful, but the trouble is, the appeal court in the provincial appeal court, like the BC appeal court, is constrained by the findings of fact of the trial judge, because they don't hear the evidence. And he made many errors in findings of fact. He made many legal errors and errors. So we are confident that eventually this decision will be overturned, because essentially what we were saying is, this has already been to the Supreme Court of Canada in the Chowley decision, and we were basically saying, should citizens outside of Quebec have the same rights, same human rights, for that the Supreme Court of Canada granted to citizens of Quebec? And if not, then we truly do have a two-tier system in Canada.
And can you remind us, the decision in Quebec the Supreme Court allowed people to access private clinics in Quebec?
Private insurance, yes. And so one of the other things which we didn't talk about, but as a result of that decision also in Quebec, they have introduced what are called care guarantees, which is another thing that we have advocated for, which is that if you are waiting beyond a certain timeline that the evidence shows there's potential risk of harm, then the government should be required to guarantee you treatment. And that means even if they have to send you to another province, a private clinic, or even to the United States, they should have a guaranteed maximum that they can keep you waiting.
So what I think I've been astounded at how vociferous the provincial government, in this case in British Columbia, and in many respects the federal government, have worked together as a team to pursue this lawsuit. And do we have any idea what kind of money they're spending? This has been going on now for years. It's incredible, the commitment and courage that people have had to support you in this lawsuit. It's quite an extraordinary story.
Well,
do you have any sense of what kind of money has been spent on the other side?
We actually went and tried to get a freedom of information request to get that data, because the government has spent, we think, maybe 70 million. We have no idea, but we went under freedom of information request to get that information, because we felt the taxpayers of the province, of the country, should be allowed to know how much their government is spending fighting against British Columbians and actually others having access to the same rights under the charter that the Supreme Court gave to Quebecers. And we were denied that figure, but that's what we estimate it is. And we'd be pleased if they opened the books and told us, because we know they were spending $40,000 to $50,000 on experts, half of whom they didn't use, even because one of the great paradoxes of the lawsuit was that many of the opposing expert witnesses, when they were on the stand, supported our arguments. I mean, it was a government expert who asserted that Canada is the only country in the world that offers that outlaws private access to private care in terms of insurance. It was a government expert who came right out and said, these patients are suffering in Canada. A government expert came out and said, you are purposefully not training enough doctors and nurses and healthcare workers because you've decided that's a way to save. These are from government experts. And it was government representatives who said, we need we depend on the private clinics for contracting out, because they do contract out treatments to private clinics. So we're very hopeful as it goes to the higher levels of court. And in Quebec, the Quebec decision was not success. The Quebec case was lost at the lower courts in Quebec also. So we're not overly disheartened, but we're hopeful of positive decision at the appeal court when it comes down, but we know they're constrained, and we're more hopeful still of a decision later on. But as I say, this brings up the question, what is the point of having a Charter of Rights and Freedoms in Canada when you are faced with a government that uses tens of millions of dollars to fight you, and you don't have those resources?
It really is bizarre.
It's almost a waste of time having a Charter of Rights and Freedoms.
Well, I think that's a very good point, Brian, because in many respects, this whole tragic saga is almost reflective of kind of a patronizing view of government that assumes that they have a right to ration this type of service, but most significantly, constrain your freedom of choice and decision that affects you as a person and your body.
Right. I mean, it's like, one of the points, it's interesting. Some of the other controversial, if you like, Supreme Court constitutional decisions have been argued on the same kind of basis that we're arguing this. And one of the lines I have used to describe what we're fighting for is that in the assisted dying case that went to the Supreme Court of Canada, some people call it assisted suicide, for patients with terminal illnesses, the government, the law was that they were allowed, an individual is allowed to access assisted dying. Mm-hmm. So one of the points I've made is that the Supreme Court of Canada has ruled that patients who are dying have a right to die without pain and suffering. Our case is about arguing that patients should have a right to live without pain and suffering. Exactly. And I think that that's something that we have to emphasize in terms of a parallel with that decision.
Indeed. Now, I do have a question, and that is, Dr. Brian Day, are you familiar with the work of Sir Roger Douglas in New Zealand so many years ago to allow for healthcare spending accounts? Is that a possible solution?
I think it would be a good solution. It's one of the basic methods used in Singapore, which has been ranked one of the top, if not the top health system in the world. They spend about half of what Canada does and have no wait list. But Sir Roger Douglas, yes. There's another New Zealand former Labour minister in New Zealand called Aubrey Begg, who basically pointed out that arguing for choice and an option New Zealand, the being able to offer an option to the government monopoly is not a right-wing issue. It's what's valid in a free and democratic society.
Yes. Well, and I think the way you characterize it, I think, is very insightful. It's a human rights issue
Yes.
on so many levels. And I think that the question I'd have to just clarify that the question that's on the chats now, people are welcome to pose their questions to Dr. Brian Day, is how would a healthcare spending account work? How can you explain that to everyone?
Well, yes. I mean, people. It is weight income related, and you have these medical savings accounts where you put money into them, and then you use that money to access healthcare. But you have to have allowances in there for low income groups. And so one of the points that's very important in this whole topic is what happens if a low income person doesn't have the funds, cannot afford a savings account, and can't afford private health insurance? Well, the answer is very simple. The government pays private insurance. So in Switzerland, for example, where the system is mostly, and in Holland, the system is mostly based on private insurance, the government the government will pay the premiums for people who are in low income groups, just as in Canada now. In a lot of welfare recipients receive the drugs and the physiotherapy and the dentistry funded because they can't afford it. So there's nothing to stop a government paying the fees, the insurance for low income groups. It's just that the reality is that people who earn more should be required to pay some premiums towards their health insurance. It's the exact opposite of what the government's trying to portray this as that it's a privilege for the wealthy. No, the wealthy should be required to pay more, and we should give free health care, but in a timely manner, to low income groups.
And I find that an interesting policy principle in the sense that you're creating an incentive then for people to also take ownership for their health. We know that our healthcare system isn't just simply the public monopoly. It's more profound things like preventative medicine. Like I try to go to a gym. I try to eat well. I need to do a better job at that. But and it's those kinds of ownership for one's health that is so critical here. And how do we design a system like those other countries that would actually create those explicit incentives?
I think it's important to point out too, that countries like New Zealand, you're talking about Sir Roger Douglas, and England and Germany and France and Belgium, these countries, unlike Canada, also cover prescription drugs, physiotherapy, ambulances, dentistry. Wow. These are not covered in Canada for some bizarre reason. It makes no sense that we insure the cost of diagnosing pneumonia in the public system, but don't pay for its treatment. It makes no sense.
Wow. So they actually have, and we can certainly go through the details of these ways of measuring performance through many indexes, but ironically, you have systems that are per capita spending less money. They have better results, better performance, and they're covering even a broader array of services than they are in Canada. This is quite remarkable.
I think, one of the things we touched on recently, but it's something that I think we need to emphasize is that a study was done comparing the bureaucracy in public healthcare in Canada and Germany. And one of the facts that came out was that for every public health bureaucrat that Germany has, Canada has 11.
Wow.
And that shouldn't surprise us. We have 14 ministries of health. Each has a minister and a deputy minister and associate deputies, so on down the line. 14 ministries. A country like France with double the population has one. Guess where the money goes in our system? It's going to this over-bloated bureaucracy, and the government comes out with false data, which they're well known for. We see it with COVID, in which they say we only spend a few percent on healthcare as administrative costs. They're absolutely false, their statement, because we at the CMA were presented with a study on administrative costs in Canadian health Medicare compared to Medicare in the United States. And it was 7 to 8% of total costs in the United States, 16 to 18% on administrative costs in Canada. The figures that the government gives us are false, and the part of the reasons they do not include any nurse or doctor who is an administrator is counted as in their funding system is counted as medical, not administrative. They don't count capital costs and buildings and equipment replacements. So we're getting fudge data from the government on administrative costs. And those figures of 11 to 1 public health bureaucrats should make the public cringe.
Wow, it's really quite an incredible story, Dr. Day. I do have one final question as we look to wrap things up, and that would be, what should we as Canadians do about this? How can we improve and even heighten the level of awareness and discussion and the need to move and change our system for the better? What would your advice be?
Well, I think the public has been pretty well kept out of decision making here. We know from polls that 80% of the public, between 76 and 80% of the public, want change. In Charlie, the majority of the public in nationally and in Quebec supported the Charlie decision, and so it's a question that the government hasn't done what the public want on healthcare, because most people understand that change has to happen. At least once you get to the health, once you are in need of healthcare, you realize that it's not there for you. And so I think actually we're in the hands of the courts right now. And I think this is going to have to play out in the at the Supreme Court of Canada eventually, and probably a year or so from now. And hopefully they will emancipate patients who've been, patients are literally constrained by government, authoritarian government laws in Canada.
Well, we certainly wish you all the best, Dr. Brian Day, and we certainly invite everyone to speak up appropriately with their elected representatives. Otherwise, no one will hear them. But Brian, you have been a friend and a friend of Frontier, and indeed, you're one of our nation's leading voices for a healthcare system that is indeed patient-centered. And so bravo on you for helping to lead and being a courageous voice in your leadership.
Thanks, David.
So thank you, everyone, for joining us here on the Frontier. I encourage you to keep involved with Frontier. We welcome your feedback and comments. Be sure to join our next Policy on the Frontier on February 24th next week, where we will welcome the Honorable Dan Mateague. He is the president of Canadians for Affordable Energy. Dan will be joining us to discuss Canada's energy policy and its full move away from affordable energy to expensive energy. How did this happen, and what does this mean for you and our entire nation? I also want to note that on March the 24th, we're delighted to have Frontier Senior Fellow Susan Martinuck, who will be talking about the book that we just referenced earlier, Patients at Risk, Exposing Canada's Healthcare Crisis. So please join us and be sure to invite others. Thank you to all of you who donate to make Frontier possible. We do not receive any government funding, so your support is much appreciated. Frontier is nonpartisan, and we do not, again, accept any government funding. And we are very grateful for all your donations. So that's it for today. And remember, without open discussion and debate, you're not thinking, and nor are we a free nation. So keep asking good questions and do not be afraid. And on behalf of all of us at Frontier, my name is David Leese, and thank you for joining us.